You when you think about injecting something into the human body, you kind of just assume the body acts like a simple one-way valve, right?
Yeah, exactly.
Like filling up a water balloon, you put the water
Hmm.
in, you pull the nozzle out, and the rubber just immediately snaps shut. The water stays securely inside.
Right. You assume the skin is this impenetrable, perfectly self-sealing barrier. You expect simple, predictable physics.
But in reality, when you start looking at the actual mechanics of getting a medical suit to stay inside human tissue, you suddenly realize that that water balloon has a lot of microscopic vulnerabilities.
It really does.
We're looking at an anatomical landscape that is actively trying to push everything right back out.
Oh, absolutely. I mean, it is a constant battle against pressure and biology.
Yeah.
And understanding how clinicians actually win that battle, how they get fluids to stay exactly where they belong is absolutely crucial for anyone interested in modern medical or aesthetic procedures.
Welcome to today's deep dive. Our mission today is to look at the hidden physics, the fluid dynamics, and honestly, the fascinating human anatomy behind injections.
Right.
Specifically, we want to uncover how medical professionals prevent something called product reflux.
Which is just a fancy way of saying, the fluid leaking right back out of the micro-puncture needle trap.
Exactly. And we are looking at this challenge specifically in the context of hyper-lax, friable, or incredibly fragile tissue. So to map this out for you, we are pulling from a highly technical stack of sources today.
We really are.
We're looking at clinical guides on injection techniques, equipment engineering manuals, aesthetic clinic protocols, and a highly unusual, almost bizarre medical case study from a wilderness medicine journal.
Yeah, that one is pretty wild.
It's crazy. We're going to look at everything from the structural engineering of the syringe itself to the molecular weight of the fluids to the physical maneuvers clinicians use to essentially outsmart our own skin. Okay, let's unpack this because reading through these engineering manuals, the amount of physical pressure happening inside a standard syringe is kind of terrifying.
It is.
Before we even talk about fluid inside the skin, we have to talk about leaks happening before the product even leaves the practitioner's hand, right?
Right, because that's where the failures often start.
I was trying to picture injecting something like a thick hyaluronic acid dermal filler. It feels like trying to force a thick, frozen milkshake through a tiny cocktail straw.
That's a really good way to visualize it.
Eventually, if you push hard enough, something structural has to give.
And it usually is the syringe itself that gives way. I mean, there was a recent survey of 87 dermatologists conducted by the Marketech Group, and almost half of them, 45%, reported experiencing hyaluronic acid leakage from the syringe itself during a procedure.
Wait, almost half?
Yeah, 45%.
That is not a rare glitch. That is a massive structural failure happening right in the practitioner's hands. Why is the failure rate so high?
Well, it comes down to a property called high G prime. These viscous fillers are incredibly cohesive and firm. They strongly resist deformation. So when a clinician pushes the plunger, that gel doesn't just flow smoothly like water.
Right.
It acts almost like a solid, exerting massive back pressure against the tip of the syringe. And fluid always looks for the path of least resistance.
So it attacks the weakest point in the system.
Exactly, which is usually the lure lock adapter.
Right, and the lure lock is that little twisting plastic thread that connects the syringe barrel to the actual metal needle.
Yeah. So the pressure literally forces the threads of that lure lock to rotate, disconnect, or just pop off entirely.
Oh, wow.
And the immediate mess on the patient's face isn't even the biggest problem there. A loose lure lock allows ambient air to get sucked into the hub of the needle.
Oh, yikes. Which means, as you continue to push the plunger, you are introducing a dangerous air pocket directly into a living organism's vascular system.
Precisely. And the syringe failures go beyond just the lure lock, too. You have defective plunger seals breaking under the strain.
Right.
You also have an issue called needle misalignment. This happens frequently with microsyringes using universal needles. If the base of the needle doesn't sit perfectly flush against the 0 mark at the bottom of the syringe barrel, it creates a tiny empty pocket called dead space.
Yeah, I saw that in the engineering manuals. And if you were trying to handle incredibly small volumes of fluid, say under 5 microliters, that dead space becomes a major liability.
It really does.
Because if 2 microliters of your sample get trapped in that tiny gap, you are delivering a significantly lower dose to the patient than you actually intended.
Exactly. And the length of the needle drastically alters the physics for those tiny volumes, too.
Right.
The engineering guides specifically recommend using a needle no longer than 1 inch for volumes under 5 microliters.
Okay, why is that?
Because if you use a longer, flexible needle, a static effect is created as the metal naturally shakes and vibrates during use.
Interesting.
Yeah, it creates a splattering effect inside the needle shaft. You virtually lose your entire tiny sample as droplets clinging to the inside of the needle before it ever even reaches the patient.
It's just wild how many mechanical variables have to be balanced here. You have to match the thickness of the fluid with the exact width and length of the needle.
Right.
You'd think, oh, just use the thinnest needle possible so it doesn't hurt the patient. But if the fluid is too viscous, a tiny gauge needle makes it impossible to physically build enough pressure to actually push the sample through.
Yeah, and this viscosity issue completely compromises a critical safety step called the aspiration test.
Right, and just to clarify for you listening, this is the safety check where the clinician inserts the needle into the skin, but before they inject, they pull backward on the plunger for about 5 to 10 seconds.
Exactly.
They're trying to create a vacuum to see if any blood pulls into the syringe, which would tell them they've accidentally parked the needle inside a blood vessel.
Right, but because these high G' fillers are so incredibly thick and cohesive, they can actually form a solid plug inside the hub of the needle.
Oh, so it just blocks it.
Exactly. Even if the clinician has punctured a major vessel, the thick gel acts like a cork. The blood cannot physically break through that gel to enter the syringe.
Wow.
So the clinician pulls back for 5 seconds, sees no blood in the barrel, assumes they are safe, and injects directly into the artery.
That is terrifying.
It is. It's a false negative caused purely by the physics of the fluid's viscosity.
Okay, so if the pressure inside the syringe is that intense and the fluids are acting like physical corks, how on earth do clinicians inject this into delicate human tissue without just blowing it apart?
Right.
Especially when we're talking about treating skin that is already compromised.
But well, we have to look at the canvas itself to understand that. Like,
Wow.
what happens when this highly pressurized fluid meets extremely vulnerable, friable tissue?
Friable is one of those medical words that just sounds unpleasant.
It really does.
It means easily damaged, crumbling, or prone to tearing. And the clinical protocols we looked at used a specific skin booster called Hyrin as their primary example for treating this kind of tissue.
Right.
And the structural statistics of this tissue are just fascinating.
They are. So when the water content in your stratum corneum, which is the outermost layer of your skin, drops below 12%, your epidermis essentially turns into dry, fragile paper.
Wow.
And keep in mind, the epidermis is only about 0.02 millimeters thick to begin with.
That is unbelievably thin.
Yeah, and when it dehydrates below that 12% threshold, it develops invisible microcracks and completely loses its elastic rebound. If you pinch it, it stays tented up. It takes forever to snap back.
Okay, I am struggling to make sense of the protocol here. You just established that this dehydrated skin is essentially like fragile 0.02 millimeter tissue paper.
Right.
But the treatment manual states that clinicians use ultrafine 32 gauge or 34 gauge nanoneedles to punch 120 to 150 individual holes into the face, delivering tiny microdroplets of this Hyrin booster. My intuition says you've just destroyed whatever protective barrier was left. Why doesn't the fluid just instantly weep back out of those 150 puncture tracts like a leaky sieve?
What's fascinating here is that the answer lies in the highly specific engineering of the fluid itself, paired with the absolute mathematical precision of the injection depth.
Okay.
You cannot just spray this into the skin and hope it stays. The injection depth must be exactly 1.2 millimeters.
Yeah, the protocols were incredibly strict about that number.
Extremely.
If the clinician goes even slightly too shallow, say below 0.8 millimeters, the product loss rate jumps to over 20%.
Right.
The fluid just immediately flows back out the hole, or it gets trapped too close to the surface and forms visible, unwanted bumps that basically look like mosquito bites.
Exactly. And even if they hit that perfect 1.2 millimeter depth, the physical puncture sites left by those ultrafine 34 gauge needles still take about 60 minutes to naturally close and seal themselves.
Which totally explains why the aftercare rules are so intense.
Oh,
If a patient washes their face or exposes it to water within 6 hours of the procedure, their risk of infection spikes by 15%.
Yep.
Because those micro-puncture tracts haven't fully sealed on a microscopic level. External tap water gets into the holes, mixes with the hyaluronic product, and the two leak out together, bringing bacteria along for the ride.
Right, and this is where the biochemical engineering of the fluid steps in to do the heavy lifting.
Okay.
Because the fluid itself is designed to fight that leakage from the inside out. The higher-end booster uses massive hyaluronic acid molecules. Specifically, they are engineered to be 1.5 million Daltons in weight.
Dalton is just a unit of molecular mass, right? But 1.5 million is huge.
It is massive. And because they are so large, they don't just sit in the tissue as a liquid. They actually form a dense three-dimensional mesh beneath the skin.
Oh, wow.
Yeah, they act like physical anchors, gripping the surrounding water molecules in the tissue so tightly that the moisture remains trapped there for over 10 days rather than evaporating out of those micro cracks.
That is incredible. And the formulation goes even further. The solution is buffered with 0.9% sodium chloride to maintain an isotonic pH of exactly 7.2.
Right.
Which I know sounds like reading a chemistry textbook, but the mechanical result of this is brilliant.
It really is. It creates an osmotic pressure of 280 to 320 milliomoles per liter.
And osmotic pressure is basically a microscopic tug-of-war for water.
Exactly.
If a clinician injects a fluid with a highly imbalanced pressure, that new fluid aggressively sucks water out of the surrounding skin cells, which the patient feels as a sharp burning pain.
Yeah, it hurts. But by engineering the fluid to exactly 280 to 320 milliosmoles, it matches the body's natural extracellular fluid perfectly.
So it's a perfect tie in that tug-of-war.
Exactly. The body cells don't swell up, they don't shrink, and most importantly, the immune system doesn't recognize it as a foreign invader.
That is so smart.
Right. It doesn't trigger an inflammatory response to push the fluid out. By mimicking the body's own chemistry, the fluid convinces the tissue to accept it calmly, which drastically reduces the chance of rejection or reflux.
So chemistry stops the body from actively trying to expel the fluid via inflammation, but that doesn't completely solve the problem of the physical highway left by the needle itself.
No, it doesn't.
Especially when we are talking about deeper injections. And here's where it gets really interesting, because clinicians have developed a physical manual maneuver that acts almost like a staggered airlock on a spaceship to permanently seal that hole.
You're referring to the Z-track method.
Yes. With a standard injection, you just stretch the skin, push the needle in at a 90-degree angle, inject the fluid, and pull the needle out.
Right, which leaves a straight, direct tube from the muscle up through the fat, right out to the surface.
Exactly. And the liquid can just travel backward up that straight path, leak into the subcutaneous tissue, and cause pain, skin staining, and it means you aren't actually absorbing the full dose of the drug.
Right. So the Z-track method was designed specifically to physically sever that backward leakage path for deep muscle injections.
And the mechanics of it are simple but brilliant. The clinician uses their free hand to grab the skin and the subcutaneous fat, and they physically drag it 3 to 4 centimeters to the side or downward.
Yep.
They're manually pulling the top layers of the body completely out of alignment with the muscle underneath.
And while holding that tissue securely off-center, they insert the needle at a 90-degree angle deep into the muscle.
Right.
This obviously requires an injection site with a significant amount of movable tissue, at least 2.5 centimeters deep, which is why it's usually performed on the thigh or the buttocks.
Okay, so they inject the medication incredibly slowly.
Right.
The rule is about 10 seconds per milliliter.
Right.
And then comes the absolute most crucial step of the entire process. Once the syringe is empty, they don't just pull it out.
Yeah, they have to freeze.
They leave the needle fully inserted in the body for 10 full seconds.
And that pause is non-negotiable. It allows the fluid time to begin dispersing into the muscle fibers, rather than pooling right at the tip of the needle where it could easily follow the metal shaft back out.
And then the mechanical shift happens. The clinician withdraws the needle and instantly releases the skin they were pulling to the side.
Right.
All those layers of tissue, the skin, the fat, the fascia, snap back into their original resting positions. And when they do, that straight needle hole is broken.
Exactly.
It turns into a disconnected zigzag path, a Z-track.
The inner door and the outer door of your airlock no longer line up. The medication is physically trapped beneath the subcutaneous layer.
It's so cool.
Yeah.
But there's a huge warning in the clinical protocols about this. Unlike a normal flu shot where the nurse might rub your arm afterward, you must never massage a Z-track injection site.
Yeah, that is a big no-no.
Rubbing the area compresses the tissue layers and can actually force the tracked medication right back up through the staggered holes, ruining the seal and causing the exact leakage you just worked so hard to prevent.
It is a beautifully engineered physical seal. But as we noted, it requires thick, movable tissue. It requires depth.
Right, so the Z-track is a brilliant mechanical lock,
Yeah.
but it completely relies on having 3 to 4 centimeters of thick, movable fat and muscle.
Exactly.
What happens when a clinician has to work under someone's eye, like in a tear trough, where the skin is paper thin and practically glued to the bone? You can't exactly drag that tissue 4 centimeters to the side.
You certainly cannot. So for shallow, high-risk areas, clinicians pivot away from sharp needles entirely and utilize blunt-tip microcannulas.
Okay, and a cannula is basically a tiny flexible tube.
Right.
But because the tip is rounded and blunt, it can't actually pierce the skin on its own. The clinician has to use a traditional sharp needle to make a tiny pilot hole first.
Yes.
The rule of thumb is that the pilot hole needle has to be 1 gauge larger than the cannula. So if you were using a 27 gauge cannula, you make the entry hole with a slightly larger 26 gauge sharp needle.
Exactly. And once the pilot hole is made, the blunt cannula is inserted with an initial angled descent to get down into the correct tissue layer, followed by a horizontal advancement deep into the tissue.
And this horizontal movement is what helps prevent reflux.
Right, it is.
Because the tip is rounded, as it moves horizontally, it pushes the tissue and the blood vessels safely aside rather than sluicing straight through them like a microscopic sword. It weaves through the anatomy.
Right, and this natural weaving discourages any straight-line reflux back to the entry point. The filler is then laid down in a linear retrograde fashion, meaning the clinician injects the fluid slowly as they pull the cannula backward out of the tissue.
Okay, that makes sense.
However, there is a very counterintuitive piece of physics regarding cannulas that practitioners must navigate here.
Oh.
You might naturally assume that a thicker, wider cannula is more dangerous because it's larger, right?
Yeah, that would be my guess.
But the sources point out that finer cannulas, like a tiny 27 gauge or 30 gauge, are actually far more likely to penetrate a small blood vessel than a thicker 23 gauge cannula.
It's all about surface area and the distribution of force.
Exactly.
Like, think of a 100-pound person stepping on your foot in a wide, flat sneaker. It's heavy, but the weight is spread out over a large surface area.
Right.
That's your thick 23 gauge cannula pushing the blood vessels safely aside. Now, put that same 100-pound person in a stiletto heel. All that force is concentrated on a tiny pinpoint.
Yep.
That's your thin 27 gauge cannula. Even though the tip is technically blunt, the concentrated force makes it incredibly sharp in practice.
And the clinical data shows it takes only a minuscule 0.23 kilograms of force for a fine 27 gauge cannula to slice right through the wall of a facial artery.
Wow.
The concentrated pressure literally turns a blunt tool into a cutting instrument.
Which proves you can't just rely on the tool to keep the patient safe.
Absolutely not.
But speaking of relying on tools, the aesthetic industry is in a bit of an arms race between human biology and engineering right now.
Oh, definitely.
We looked at automated injectors devices like the One-Eed Pro and various K-Beauty injector guns used for ultra-shallow skin booster work.
Right.
And these machines use something called a sealed safety system with no flow technology to ensure zero backflow.
Yeah. They are essentially trying to mechanize the process to completely remove human error.
Right.
These devices use auto-sensing negative pressure. They literally act like miniature vacuums, pulling the skin tight against a plate of multi-needles to ensure mathematically perfect depth.
Wow.
And they inject the fluid automatically and use internal viscosity controls to prevent the fluid from moving backward.
So they are trying to outsmart the skin entirely.
Exactly.
But even these high-tech machines have a blind spot.
They do.
The clinical column from the Clear Clinic Gangnam branch explicitly noted that for patients with very thick resistant skin, the automated system often fails. The vacuum pulls, the machine fires the needles, but because the skin resistance is so high, the needles actually bend or fail to reach the desired depth.
Yeah, and the drug just leaks directly out onto the surface of the skin in a puddle.
Which completely defeats the purpose.
It does. If we connect this to the bigger picture, it really proves that technological tools do not replace anatomical understanding.
Right.
A machine can perfectly calibrate negative pressure to prevent backflow, but if it misjudges the structural resistance of the individual patient's tissue, it fails completely. Human judgment, and often a return to traditional tactile hand injections, remains totally necessary.
So what does this all mean? Are these automated vacuum devices and blunt cannulas actually replacing the physical skill of a technique like the Z-track? Or are they just trading one set of risks for another?
I'd say they are simply trading risks based on the anatomical landscape.
Okay.
A cannula reduces bruising and reflux, but introduces the stiletto effect on arteries. An automated injector guarantees depth and traps fluid in thin skin, but fails on thick skin. And the Z-Track is foolproof for mechanically preventing leakage, but is limited entirely to deep muscle. There is no magic bullet. There is only the clinician's ability to match the physics of the tool to the reality of the tissue in front of them.
It is a massive high-stakes balancing act.
It really is.
We've gone from battling the sheer back pressure inside the luer lock of a syringe to mapping the exact 1.2 millimeter depth to keep fluid from weeping out of paper-thin skin, to physically dragging tissue to create the staggered airlock of the Z-Track method.
Right. We expend a tremendous amount of medical engineering, chemistry, and physical skill ensuring that these fluids and fillers stay permanently trapped inside the tissue.
Yeah.
But this raises an important question and a final, rather wild detail from our sources. We spend all our energy trying to keep the product in. What happens to the body when the product actually stays there?
Oh man, this case study from the Wilderness Medicine Journal blew my mind.
It's incredible.
There was a 48-year-old woman who went on a 4-hour snowmobiling excursion in Wyoming. The temperature was 10 degrees below 0 Fahrenheit.
Freezing.
She was completely bundled up, wearing a balaclava, goggles, a full-face helmet. She took all the right precautions.
But after the trip, she developed a necrotic 4th-degree frostbite eschar, which is essentially a patch of severe dead tissue.
And the twist is where she got it.
Right.
The frostbite didn't happen on her nose or her earlobes or her fingertips, which is where you normally get frostbite because they're the most exposed.
I think so.
It occurred only over a highly specific 2.5 centimeter by 1.5 centimeter patch on her right cheekbone.
And that exact isolated spot was precisely where she had received a dermal filler cheekbone augmentation 58 days prior.
Almost 2 months earlier.
Yep.
The filler had done exactly what it was engineered to do. It was injected deeply, the clinician prevented any reflux, and it perfectly occupied the space beneath the tissue, elevating the skin off the bone to create cosmetic volume.
But in doing so and successfully occupying that space and lifting the tissue, it fundamentally altered the microcirculation and the blood perfusion of the skin directly above it.
The tissue was stretched tight over the filler, acting like a physical barrier.
Right.
It meant that specific patch of skin didn't have the same robust, warming blood flow from the deep vessels underneath.
Exactly.
It made that one specific, perfectly sealed patch of skin highly vulnerable to freezing, while the rest of her face was completely fine.
It is a profound visual example of the law of unintended consequences in medical engineering.
It brings us right back to that water balloon we started with. We spent all this time mastering the physical mechanics to perfectly seal these artificial substances inside hyper-lax tissue.
Right.
We engineer the Daltons.
Right.
We calculate the osmotic pressure. We pull the skin to lock the door.
Yeah.
But as we get better and better at forcing the body to hold on to things it didn't create, we have to ask ourselves, how are we fundamentally altering the way our bodies naturally interact with the extreme environments around us?
It suggests that when we change the internal landscape, we inadvertently change our external vulnerabilities.
A perfectly sealed system might just create a whole new set of leaks. Thank you so much for joining us on this deep dive. Keep questioning the hidden mechanics of the world around you. We'll catch you next time.